So I'm thrilled to be joined today by Girish Nadkarni, who is the chair of ASN's new Augmented Intelligence and Digital Health Task Force. And I was thinking about how best to introduce you, and I thought what I would do is just congratulate you on receiving the Rising Star Award from the American Nephrologists of Indian Origin. That's quite an honor, and I saw that recently, so I just wanted to congratulate you for that.
Thank you, Todd. It's a pleasure to be here, and not sure I deserve that honor, but I'll take it. So, but thank you, and I appreciate you taking the time to talk to me today.
Well, I'm really looking forward to our discussion because I have to admit this is a topic I don't know as well as I should. And so I thought I would start with some definitions. So, as I mentioned, the task force is focused on augmented intelligence and digital health. Why do we use the term augmented intelligence and not artificial intelligence?
So, I do think that the term artificial intelligence, especially in healthcare and medicine, is a little bit of a misnomer. Artificial intelligence usually relates to uh, machines or computational programs making the decisions themselves and taking in inputs, analyzing it, and making the decision themselves. So if you think about artificial intelligence, you think about driverless cars, robotics, things which are completely autonomous and make the decision themselves. And even in those industries, true autonomous anything is quite a long time away. I mean, you know this from news reports and um, the things that we hear on the media. So I think augmented intelligence is a much better term because of the fact that computers or algorithms or computational programs are working in concert with us, the physicians, in order to augment our decisions, in all help us to make better data-driven decisions. And that's why I think augmented intelligence, especially in the scope and field of healthcare, is a much better term than artificial intelligence because augmented intelligence refers to the augmentation of our clinical decisions and our healthcare operations by algorithms and by computational discipline, while artificial intelligence refers to sort of completely autonomous machines without any human intervention, which I think in healthcare is never going to happen. Does that make sense?
It does. And so then what's the relationship between augmented intelligence and digital health?
So, digital health is sort of a very big umbrella term that includes a whole bunch of things. It includes anything in which the interaction of a patient with the healthcare system occurs digitally over the medium of a computer, a smartphone, um, uh, or anything where the patient doesn't have to be physically in the hospital. So it can include things like telemedicine, in which the medium of communication between the physician and the patient is essentially a computer or a phone, right? And software in which you can communicate with the patient and make decisions together over a digital medium. It also includes things like mobile health, in which mobile apps, wearables, etc., are used to generate more data driven decisions about both healthcare as well as patient preferences towards healthcare. So, digital health is like a big umbrella term that's used to define anything in which medicine or the interaction between the patient and a healthcare system, or the interaction between the patient and anything related to healthcare, which again includes mobile applications, not just for uh, when they have a healthcare issue, but for maintaining health, is digitized.
So, as I think about the COVID 19 pandemic, on the one hand, it's acted as an accelerant in the terms of I think people have become much more comfortable, both health professionals and patients have become much more comfortable with telemedicine. On the other hand, it's also exposed real gaps in care, both within the United States, but also these inequities between the United States and other countries. How, as you think of these issues, how do you navigate both the positive that people seem more comfortable with the technologies, with concerns around sort of exacerbating a digital divide between individuals, both in the United States and abroad?
So that's a hard question, right? And it's all along with it being a clinical question, it's also a research question and it's a policy question. So I'm gonna give some broad outlines the way I think about it. And this might not be the right answer, right? One is the digital divide is very clear along socioeconomic and ethnic minority lines, right? That people who are socioeconomically deprived are mostly belonging to racial and ethnic minorities, don't have access to sort of new digital technologies, don't have access to broadband, which is sort of the information superhighway for all of these digital technologies, and as a result, they are left behind. The second thing is that individuals who belong to these minorities might not necessarily have the financial and uh, the insurance wherewithal in order to access uh, all of this digital medicine offerings, even if they become available. So I think because the problem is multifactorial, the solution also has to be multifactorial. It has to start at the highest levels of government, in which similar to other basic infrastructure that we consider necessary for human health, internet access and connect and digitization also has to be part of the basic infrastructure. And that was all reflected in the recent infrastructure bill that was passed. The second thing is that when hospitals and healthcare systems are making decisions about the availability of digital offerings, I think two things need to happen. One is that there needs to be a conscious effort to plan or to acknowledge these disparities and to plan offerings in a way to decrease the disparities, not increase them, right? For example, simple things, right? If you just make digital medicine offerings in English, then you're leaving out a large segment of the population that's bilingual or speaks Spanish. So a simple thing could be making all of those digital medicine offerings in Spanish, which some hospitals and healthcare systems, including mine, have done. Um, the second thing is that healthcare, especially for a lot of people, is already decentralized, and people, you know, uh, believe in their community organizations, churches, places of worship, community centers, etc., etc., um, uh, and rely and trust in them, right? And trust has been a big issue in medicine for minorities and will get exacerbated, especially in this digital age. So, hospitals, healthcare systems, policymakers, and organizations should work in concert with these community organizations in order to ensure, that the trust that these community organizations have built with these communities is maintained and amplified in this new age.
So you mentioned centralization, and it's hard for me to imagine a future where healthcare will be more reliant on augmented intelligence and digital health without there being sort of larger structures. And you mentioned the recent legislation that we're now thinking about this connectivity as part of infrastructure. How do you see just the future of healthcare? Let's just focus on the United States for a second. How do you see the future of healthcare evolving, where on the one hand, the individual patient has a lot more control, if you will, or a lot more information where they can be making decisions. And at the same time, you're going to be wanting to look at the largest data sets possible as you're thinking about population health and making sure that everything you and your colleagues are doing is beneficial to individual patients, but individual to the population.
So healthcare is undergoing a transformation right now, in which is becoming centralized in terms of the fact that health systems and health organizations are becoming larger and larger, and more practices and more health organizations are becoming sort of integrated into large umbrella organizations. And we've seen that, in various states all over, right? Uh, uh, for example, Kaiser Permanente sort of takes care of like one fourth of the patients in California or something of that sort. But at the same time, it's becoming a little bit decentralized in the fact that, in terms of the fact that Apple has introduced Apple Care, right, and Apple Health Care, in which you can have all of your electronic records in one place. It links up with your it links up with your Apple Watch to give you maybe action, and I say maybe because I don't know yet, actionable insights about health and disease. Pharmacies like CVS and Walgreens have opened up minute clinics in which you can get immunizations. You can go there for like minor medical issues, etc., etc. So I think there's a simultaneous process of centralization happening in which large organizations are sort of consolidating into where people, if they need to go physically see a doctor, they will see a doctor in a particular area that's affiliated with the healthcare system. But in terms of healthcare, in taking care of your own health, it's becoming more and more decentralized. So I think two things need to happen. One is that these large healthcare organizations need to start forming partnerships with these decentralized organizations, including CVS, Apple, other mobile health providers, in order to get a full picture of the patient's journey from start to finish, right? For example, if we think about electronic health records, and I don't think they should be called electronic health records because that's not a picture of your health, it's a picture of your disease. We are looking at pixels in a picture, right? We're not seeing the whole picture, we're looking at individual pixels and trying to guess what the whole picture is. But if you sort of partner with Apple Health, if you partner with CVS, if you partner with community organizations where people get sort of more healthcare, not sick care, you're sort of getting a picture of this individual patients throughout the health span. The second thing that needs to happen is uh, healthcare organizations and large organizations like ASN need to invest in more decentralized care, more at-home care. Be it doctors going to patients' homes or physician uh, uh, or healthcare providers in general going to people's homes, or even passive data collection in the form of wearables, at-home sensors, mobile applications in which you check in with patients, asking them how they are, and they send you a quick text saying that they're fine, so that you don't just get the picture of the patient when they are interacting physically with the healthcare system when they come in, but you also get the picture, sort of a more holistic picture of how they are at home, how they interact with their community, how they live their lives, right? Because that's where the majority of the action, as it were, happens. And I think finally is that all of this needs to be viewed through a lens of equity, making sure that the people that have been, again, historically underrepresented in medicine progressing are not left out of this equation. So that needs to be thoughtfully uh, done, and that needs to be sort of front and center of the agenda, right? Otherwise, this digital divide will again keep on getting worse, in which people who have access to smartphones and wearables and better insurance will receive better health care, while individuals who do not have access to these things, either because of a lack of knowledge or a lack of money, will be left behind.
So if we start to shift this discussion to nephrology specifically, and I think about sort of where you sit at Mount Sinai, it must be interesting because on the one hand, within your division, you're advocating for the institution to think more broadly, to think about these potential partnerships, which are obviously bigger than the specialty of nephrology, although there might be some unique opportunities that are nephrocentric. Then at the same time, you're also thinking about training and sort of what medical students, residents, fellows, and also your fellow faculty need to understand about these issues and sort of how they think about the next 5, 10, 20 years of their careers. And then there's this third piece of equity, which is both. It's both at an institutional level, but it's also at a sort of divisional level. If you could just help us understand sort of day to day how you see your role at an institutional level and how some of your colleagues at other institutions may want to rethink sort of where they sit in their divisions.
So that's an excellent question, Todd. So I think, well, let me just start off by saying that nephrology and is as a discipline is well poised to become one of the more leading discipline in this new age of digitization of medicine, because in nephrology as nephrologists, we are very comfortable with numbers, right? That's what we do a majority of the time. Um, so I think that nephrology as a discipline itself is very well poised to become sort of the leading edge of um, augmented intelligence and digital health in the medicine specialty. I think a few things need to have that happen. So you mentioned briefly about training. I think physicians, as of now, are very underprepared for the digitization of medicine. You know, just being honest, right? All the only exposure that we have to digital health and augmented intelligence is through the electronic health record, which not many of us like because it takes up a significant proportion of the time. But we have no introduction to sort of probabilistic thinking, right? We have no introduction to uh, uh, the basics of predictive models, for example. We have no introduction to how digital health can be used as an ally and, more importantly, can be used to maintain the physician patient relationship rather than worsen it. So I think there needs to be both didactic and experiential training programs for physicians at all levels, starting from medical students to residents to nephrology fellows to faculty, in order to train them in what's coming in the next 5, 10, 15 years when medicine will be predominantly more digitized. Augmented intelligence and predictive models will become part of routine clinical care, right? The second thing is that there's a lot of excitement about this, right? And when there's a lot of excitement about it, people want to do it without thinking of the consequences of it. So, you develop a predictive model using machine learning or on EHR data. You right away want to put it into practice without thinking of the potential consequences around it, right? Um, but I think that it's important that all of these models be, first of all, validated to make sure that they are as accurate as you say they are, and they need to be tested in randomized controlled trials to make sure that they're doing what you expect them to do and cause giving benefit to the patients and to the healthcare providers and not causing harm. So that's sort of the pipeline that we are building here, and hopefully with this new um, task force that we help to build broadly to make sure that the approaches, the data-driven approaches that we are putting into clinical care are, well thought out, well validated, prospectively tested in randomized clinical trials, and do not cause harm and cause and have benefit to physicians and to providers, right? Because um, to be honest, there's a lot of hype around this whole area, and some of the hype is warranted. But if it doesn't live up to the expectations, then uh, there can also be a plateau of disappointment that comes after a peak of hype, and we have to be very, very careful about not overhyping this and not saying that this will solve all of the problems in medicine, because I don't think that's possible for anything. I think the correct message is this will help nephrologists and help physicians solve some of the problems in medicine, but the physician patient relationship has to be at the center of all of it and not be replaced by anything, which is, and going back to your initial question, I think that's again a key difference between augmented and artificial intelligence, that augmented intelligence puts the physician patient relationship at the center of all of these things.
You'd mentioned randomized trials. So who funds research in this arena?
Very little research is funded around implementation science, to be honest, by the NIH or by other entities. And on the policy front, there needs to be a push to fund more research in this arena, right? Because if 90% or 95% of the funding is going towards developing predictive models and none of the funding is going towards implementation and evaluation of these models, there's a big disconnect there, right? So I think there needs to be a strong policy push for traditional funders, governments, philanthropic institutions, ASN, in order to think about funding these sort of implementation research. And it needs to think about funding it not just at one institution, but to make it more sort of multi-center, so that uh, once you have a readout from that, you can potentially implement it at broadly.
So healthcare in the United States is different in the sense that there's a huge federal and state component. There's a public component of it, but there's also a private component, and that private component is mostly for profit.
Mm.
As you've seen over the last couple of decades, there's more and more private equity coming into healthcare. I'm just curious, you'd mentioned partnering with organizations like Apple and other sort of perhaps publicly traded companies. What's the nexus between private equity coming in, say, and partnering or purchasing physician practices with these large companies that have expertise in this arena, and how they may just may accelerate the transformation of medicine?
So I think that's a good question. And again, I'm not sure I'm completely qualified to answer it, but I'll just give you my thoughts, right? I think there's value here for everyone if done right and if done ethically. Obviously, a lot of these for-profit companies, the bottom line is what matters to them, but doesn't have to be exclusive with doing right by the patient, right? Basically, if you think about a hospital system, they want to provide value-based care and save money. There's potential that doing approaches in a data-driven fashion while would provide more value to the patient and save money. And in if you have to do this in collaboration with private companies, uh, uh, be it on the digital health side, be it on the augmented intelligence side, be it on the prediction side, then there's value generated for everyone, right? But at the same time, uh, both healthcare organizations as well as patient-centered organizations like ASN have to be uh, especially careful about conflicts and have to be especially careful that the ultimate goal is to help the patient and the provider and not make and not help the bottom line of these companies.
So how did you first get interested in this topic? Do you remember the moment where you were like, okay, I see this. This is really interesting. I want to really focus my career in this arena.
I trained in mathematics before I went to medical school. So I was always interested in computation and mathematics, and I got interested in this when I was working during my postdoctoral fellowship in nephrology. I was working in the Institute of Personalized Medicine, and there was a lot of data-driven stuff going on, predominantly in the genomics area, but also in the electronic health record area. And I thought that we collect all of this information on our patients for essentially at the point of during clinical care, and it's all available. And can't we make harness this information in order to provide better care for the patients? And so I've been working on this for I don't know, like 10 years now.
Curious as to what you read. So if you were to give a reading list, either in terms of periodicals or books, or how do you sort of stay current in this arena? So I'm guessing it's different than sort of what most of your colleagues read.
Uh, so, well, I would recommend reading Deep Medicine by Eric Topol. That's a great book. I would also recommend going on the AMIA website, the American Medical Informatics Association, and browsing their sort of current affairs or current picks. They have usually a good selection of the new approaches. And in terms of journals, I like JAMIA, which is Journal of American Medical Association. There's Lancet Digital Health and Nature Digital Medicine. Those are the good journals I read.
So circling sort of back to the task force. So what are you most excited about?
So even though I'm like the putative chair of the task force, this was initially a concept put together by me, Karandeep Singh from University of Michigan, and Azra Bihorak from University of Florida. And thanks to Dr. Agarwal and Dr. Quagan, we got the support from ASN in order to pursue this. Um, uh, Very excited in order to work on this because I do think nephrology is my first love and it's a very data-driven specialty. So, in order to set best practices and guidelines and at least um, recommendations for the AI and digital health in the field of nephrology is, I think, a huge honor, a huge responsibility, and very excited about it. Also, very excited with working with Melissa West from ASN. I think she's a great facilitator and great administrator to work with. And most importantly, getting input from the larger ASN community and the larger nephrology community about what we should be doing, what we should not be doing, and where we should be focusing our attention on. But I think this is a bold and transformative endeavor by ASN in order to sort of not define, but at least solidify the future of nephrology in this age.
Well, and as I was listening to you, I was struck, and this was a comment you made earlier, and I didn't react to, so I'll react to it now, which is, it seems like if the task force is successful, and if the specialty embraces augmented intelligence and digital health, there's a way to reposition nephrology as a even more cutting edge specialty.
I completely agree. I think nephrology is the specialty most poised to do this because, again, we deal in numbers, right? And computation and augmented intelligence and digital health is all about numbers. So we are the most specialty most conversant in numbers. So we should be the specialty at the sort of the spearhead of this, right?
No, I agree, and I'm excited. When we saw the proposal, and I should say there's a really nice lesson here for the organization in the sense that this was something that you and some of your colleagues at a membership level came forward to the ASN Council and said, we think this is an important topic, something the organization should be focused more on. We weren't at the time, and there was clearly reaction. And I should say too that Barbara Murphy, during her term as president-elect, this was something that she felt very passionately about. And I will say was very clear on augmented intelligence as opposed to artificial intelligence. So she had heard that message from you.
Barbara was my mentor, and I was very close, and I miss her every day. And to be honest, I think she was many, many years ahead of her time. So I've dedicated my career to in order to make sure that she would be proud.
Let me just ask you one more question. We do have the AKI Now effort, which is really looking at ways to improve care for individuals with acute kidney injury. And I know they have an effort that's focused on augmented intelligence and digital health. Just kind of curious as to how your task force will interdigitate with that effort.
So AKI Now has been a great effort, and especially the AI and digital health part of it, led by Jay Coyner and Shaina Menon, has been amazing. So I'm part of the task force as well, and the plan would be to have representation from this broader task force into each one of the specialty areas of nephrology. So there will be representation on the policy front. There would be representation on the training front. There would be representation on the AKI Now front, CKD, dialysis, right? And I think what AKI Now brings is deep, deep expertise, both in the clinical, policy, and healthcare system part of AKI. And I do not see this larger task force succeeding without them.
Well, thank you, Girish, very much, and congratulations again on being the Anaya Rising Star. It's really quite an honor, and I was thrilled when I saw that announcement.
Thank you, Todd. Really appreciate it, and very good talking to you. And I hope to continue talking to you in the near future.
Likewise, thank you.